My name is Mihaela Topala. I'm a gastroenterology resident from Romania. I'm also a PhD student at Davila University from Bucharest, and I'm participating in a one-year fellowship program of translational medicine sponsored by the MOL group. My vision is that the morbidity will decrease and the quality of life will improve in IBD patients in the next years. And my mission is to evaluate interventional endoscopic procedures and surgical techniques that might improve the outcome in Crohn's disease patients. For my mission, I have two projects I'm currently working on. For both of my projects, I use systematic review and meta-analysis methodology. This is my first project, Effectiveness of Extended Mesenteric Excision in Preventing Postoperative Crohn's Disease Recurrence. It was started in September. As we all know, Crohn's disease represents a chronic condition that is characterized by recurrent flares of intestinal inflammation. Complications such as abscess, fistulas, or stenosis can be diagnosed up to 1/3 of the patient at the moment of the diagnosis. And 70% of the Crohn's disease patient will require abdominal surgery during their entire lifetime. Unfortunately, the postoperative recurrence is still high, and up to 20% of the patients will require multiple intervention. Some studies suggested that the hypertrophic mesenteric tissue secretes large amount of pro-inflammatory and pro-fibrotic cytokines that might have a role in the Crohn's disease pathogenesis and progression, and that it might even influence the postoperative recurrence rate. So my aim is to evaluate the effectiveness of extended mesenteric excision in preventing postoperative Crohn's disease recurrence. To clarify the terminology, in a limited excision, the mesentery is cut closely to the intestinal wall, and in the extended excision, the mesentery is mobilized and divided close to the major arterial trunks or close to the mesenteric root. My clinical question is whether the extended mesenteric excision is associated with lower rates of postoperative complications and postoperative recurrence compared with limited excision in Crohn's disease patients who underwent intestinal resection. And for my clinical question, I used the PICO framework, and my hypothesis was that this intervention is associated with lower rates of complication and lower rates of postoperative recurrence. We did a systematic search in November, and after the selection process and the citation searching, we had 6 papers for 5 studies. 3 of them were included in the quantitative analysis, and 2 of the studies were included only in the qualitative one. And now I want to show you the results. This forest plot evaluates the surgical recurrence, which was defined as the need for surgical reintervention after the index surgery to the Crohn's disease recurrence complications. Considering the high need of surgical intervention, and despite the fact that we are living in the biological area, the recurrence rates are still high. We need to find some new strategies to improve the surgical burden in Crohn's disease, and that's why we choose this as our main outcome. The overall odds ratio we are interested in, the measure of effect we were interested in was odds ratio with 95% confidence interval. We included 3 retrospective cohort studies that reported data mostly from prospectively maintained databases. The follow-up period varied between 47 and 69 months. As we can notice, the number of the patients varied between the studies. Moreover, the study with the highest effect reported was the study with the smallest number of patients. And all these factors, together with the small number of studies included, could explain the moderate level of heterogeneity of 45%. All studies reported the same effect, and we have an overall odds ratio of 0.3. Clinically, it means that patients who underwent intestinal resection with extended excision were 3 times less likely to develop surgical recurrence compared with patients with limited excision. But our result is not statistically significant, so we'll need more studies. The second outcome is the overall postoperative complications rate. We included patients who had any type of postoperative complication. We included the same studies we reported in the previous outcome, but this time the level of heterogeneity was very low. The overall odds ratio was 0.78. Clinically, it means that patients that performing extended excision will decrease the odds of having postoperative complication by 22%. Compared with limited excision, but again, our results are not statistically significant, so more data is needed. Our study has some strengths. It represents a comprehensive analysis of an emerging topic in Crohn's disease surgery, and also I want to mention the rigorous Cochrane systematic review methodology that we used. But it also has some serious limitation, and I will start with the limited data. We only included three studies for this meta-analysis. All of them were observational cohort studies, and moreover, the small number of patients included, together with the high level of inconsistency and imprecision of the results, downgraded the certainty of evidence to low and very low. In conclusion, extended mesenteric excision appears to be a safe procedure, and it might have a positive impact on long-term postoperative recurrence, but at this moment the evidence is very uncertain. So although it's safe to be implemented in clinical practice, we don't have enough evidence to recommend it to be implemented routinely. But there are some implications for future research. First of all, we need more studies. We need multicentric, large samples, randomized controlled trials that should also evaluate the clinical and endoscopic recurrence and should have an analysis for specific anatomic segments, for example, for colonic resection and ileocolic resection. And also the role of microbiome and the immunological aspects in this process have to be clarified. Now I'm writing the manuscript, and I plan to submit this article in May 2023. And this is my second topic, efficacy and safety of endoscopic balloon dilation for Crohn's disease strictures. As we already know, the main concern in Crohn's disease is the high risk of developing complications. And studies have reported that after 20 years from diagnosis, almost 60% of the patients will develop intestinal strictures. Unfortunately, the efficacy of medical treatment is very limited, especially for the fibrotic strictures, so we have to perform invasive procedures, such as surgical ones, or when it's feasible, it is preferred to have endoscopic treatments. And I have to mention that endoscopic balloon dilation is the mainstay of the endoscopic treatment, and it is also recommended in the latest ECHO guideline. So my aim is to evaluate the efficacy and safety of endoscopic balloon dilation for Crohn's disease strictures. And my clinical question is how effective is this procedure in decreasing the need for surgery in Crohn's disease? For this question, I will use a COCO-POP framework, where population is represented by Crohn's disease patients with intestinal strictures. The context would be performing endoscopic balloon dilation, and conditions are post-procedural complication, short-term and long-term efficacy. My hypothesis is that endoscopic balloon dilation has low rates of complication and high rates of clinical efficacy, and that would reduce the need for surgery and would improve the long-term outcome. In December, we had a preliminary research, almost 13,000 hits. There are some meta-analyses published, but also new data is available, so we plan to have an updated meta-analysis that I want to submit by September 2023. Thank you for your attention, and I want to end with my favorite quote, "Everything is possible until it's done."
It's common knowledge that this, regarding your second project, that these strictures react better for biodilation when the strictures doesn't consist of inflammatory fibrotic tissue. You mean what I would like to ask, so that how would you limit your search for strictures which are caused by an active inflammation, or which are caused by a chronic inflammation which already resulted in a fibrotic stricture?
Thank you for your question. We'll focus on the fibrotic strictures, for which the recommended treatment is either a surgical intervention or balloon dilation if they are under 5 centimeters long. This is the recommendation for the ECHO guidelines. But we can also investigate this issue of the length of the stricture in our project to see if balloon dilation is effective for longer strictures, for example.
I think that the question was that how do you differentiate between a stricture that it's good for dilation, for 4 centimeter long, for example, and if there is an inflammation itself or just fibrotic tissue? How could you select in the publication?
If there would be active inflammation, it could be easily visible to the CT scan. So there are some criteria that would differentiate between fibrotic old strictures and active strictures.
And you would include studies only with active strictures?
No, I want to include the studies with chronic strictures. Because for the active inflammation, the first treatment is biological.
I would like to ask you regarding your first project, how long was the follow-up in the studies for the evaluation of surgical postoperative recurrence?
In our included studies, it varied between 47 and 69 months. And there was one study, the study of coffees. It was the study with the smallest number of patients and the highest effect. And it actually compared 2 cohorts. One of them had a longer period of follow-up, so I think it could be a confounding factor for our result.
Have you looked for endoscopic postoperative recurrence rates?
Yes, it was one of our outcomes, but only one study we reported the endoscopic recurrence, and there wasn't a significant difference between the 2 groups.